All right, everyone. So again, thanks for coming. I think we'll get started. It's just 5 after right now. Today, we're going to talk about death in the emergency department and the role of the coroner and kind of all the logistics surrounding death that occurs on shift. So my name's Dylan. I'm one of the plus ones this year. For those of you who haven't met me, I'd like to give a big thanks to Dr. Mywald for supporting me in this project and helping us decide on a topic that hopefully is worth your while for coming out today. And then a big thanks to Dr. Reeder, who we're fortunate to have on the call today for his guidance and wealth of knowledge that he provided for this presentation. So none of us have any disclosures, and right off the bat, I'll hand it over to Dr. Mywald and Dr. Reeder to discuss a case for the start.
Okay, good morning, everyone. Just because I see that the Western FRCPC residents are probably together watching this, can someone write in the chat for me who is a couple of names of who's around, just so I know who to ask questions to? I can open the chat on another computer, just so I don't inadvertently ask someone who is not here. Okay, so we're going to start with a case. This is a case I had about a month ago, I guess. So CTES 2, 32-year-old male. He's placed in B10 at Vic. It's Monday. And his chief complaint is weakness and body aches. So the triage note says, patient from home, unwell since Friday. This morning states temporary loss of consciousness for about 15 minutes, increased weakness, generalized body aches, numbness to bilateral legs, pale, diaphoretic, blood noted in mouth, no obvious trauma noted, no falls, no trauma. I'm sorry, I got to find that, go for it. And then so I was actually called to assess for a blood pressure of 54. So myself and 2 other staff, as well as a resident, went over, the 2 staff that were on 0400. And so we went over. So while I was getting some history, the nurse was putting in a second IV. The resident was looking up the patient's chart online. So he had a 3-day history of nausea, vomiting, diarrhea, dark but not black stools, no hematemesis. He's had mild diffuse abdo pain, some mild central chest pain, and feeling very cold. No fevers, no rash, no cough, no lower urinary tract symptoms, no sore ears, and no sore throat. He was positive for antiphospholipid antibody. He did have a DVT at age 14 that was treated with warfarin, and he did have ITP as well. His last course of steroids for this was 8 months previous. So once we kind of got IV fluids on a pressure bag, his systolic blood pressure was 70, heart rate was 120, respiratory rate 36. Temp 36.4, satting 92% on room air with a gluc of 7. He looked exceptionally unwell. He was pale, mottled from his clavicles to his toes, cool to touch, but he did have dorsalis pedis pulses. He was tachy with no murmur, no peripheral edema. His chest was clear anteriorly. His belly was soft, some mild diffuse tenderness, and his oropharynx was exceptionally dry. So what are we going to do now? So I'm just going to pick someone that I saw the name that has signed in. So let's do Brandon. What do you want to do now, Brandon? I'm not sure we can hear you.
Can you hear me?
Mm-hmm.
So it sounds like we've already got some IVs, we're getting a history. I'd like to probably get some fluid started, potentially think about transfusion, probably have low platelets, low hemoglobin, some other things. It'd be good to draw basic labs at this point, including coagulations. And then continue fluids going in, possibly think about getting some vasopressors started, giving this low blood pressure. We'll see how it responds with the initial fluids though.
Okay. So basically that's what we did. We gave phenyl push dose, 200 mics IV. We did give Piptazo. He had IV fluids on 2 pressure bags, and we did a quick quick POCUS while still in B10, and there was no pericardial effusion and no AAA. So we moved him to trauma. We placed a right radial art line, a right femoral central triple lumen, as well as a Foley catheter. He did respond very well to the phenyl, but it was exceptionally short-lived, but did respond well. So we did start him on Levophed. We did put a bear hugger on him. He didn't tolerate it. He found it just to be very hot, he said. Portable chest x-ray. I thought it was nil acute, at least on the portable machine. It was read later as query right lower lobe opacity infiltrate versus atelectasis. So this was his blood gas plus that came back. So pH 6.96, PCO2 55, bicarb 14, lactate 11.9, and hemoglobin 168. So it sounds like they're having technical issues where the FR residents are. So my apologies to the EMs that you might get called on a little bit more. But Jesse, what are you thinking at this point could be going on?
It looks like he's in metabolic acidosis. His lactate is high. That could potentially be the cause. With the history of the vomiting, he could have an obstruction. With that high lactate that could be driving all of this.
Okay. Any other ideas what the underlying source could be? And what do you think your overall kind of gestalt diagnosis at this point is?
Sorry, I can't remember if he had any signs of GI bleed.
Just dark, but not black stools. So tachy, hypotensive, tachypnic, nausea, vomiting, diarrhea for 3 days, very cold.
I mean, he's in septic shock.
Exactly.
Yeah.
At this point, not exactly sure why, but that's where he is.
Yeah, I like his abdomen right now, like abdominal.
Yeah, and this is what we were thinking as well. Okay. So his white blood cell count came back at 10.5. His creatinine came back at 435. Urea was 38.8. The potassium was 5.8, but it was slightly hemolyzed, and the trope was 40. So I had already ordered the CT abdo-pelvis. So I discussed it with him and his partner, and we did ultimately decide to proceed with the CT. And ultimately, I also consulted nephrology at the same time as kind of he was rolling out to the CT scanner. So he went to the CT scanner. And came back to pod B. He was on, he's now been lined, he's still getting fluid boluses, and he's on Levophed of 10 at this point. His CK came back at 11,905, his urine looked positive, and then I gave the CCTC a call. While I was on the phone with CCTC, the clerk in the front bubble at Vic slid a piece of paper across the desk at me to let me know his platelet count was 1, which was suboptimal to say the least. And then while I was on the phone with CCTC, he arrested in BPOD. So we proceeded with resuscitation according to ACLS protocol. He was intubated. In case his potassium had gone up, we shifted him. There was an intermittent faint pulse wide complex. Given that his potassium was normal earlier, we weren't sure if this wide complex was due to a potassium issue. We didn't think so, but that's why we shifted him just in case. We wondered if it was VT, so we cardioverted him. We gave him amio and eventually an epi and a levo infusion. So while we're doing this, the CT abdo-pelvis came back with no conclusive evidence for bowel ischemia. There was some upper GI tract fluid that was non-specific. While we were doing CPR, we also consulted CBT for ECMO. And then that's when we also noticed that he had unequal pupils. His left side was blown. So Delia, what does that make you concerned for? Is Delia there? Okay, let's try
I'm
Miriam.
so sorry. I was just having technical difficulties. My apologies. I would just be worried about uncle herniation at this point of time. If his left pupil is blown, that would make me think that he's got third cranial nerve compression, which would be from an ipsilateral uncle herniation.
And what would be the likely cause of the increased pressure in his brain?
Given that his platelets are, you mentioned 1, I'm worried about an intracranial hemorrhage.
Yeah, so that was our worry as well. And CBT, obviously, they were already very on the fence about ECMO, given that he only had a platelet count of 1. They really didn't want to heparinize him. And so if he had a brain bleed, they certainly weren't going to heparinize him. So we decided we needed to get back to the CT scanner if at all possible. So when he had one of his intermittent faint pulses, off we went. At this point, the CCTC resident had arrived as well. So we get to the CT scanner. Of course, he goes VSA before we get him on the table. And this was kind of the story for the next 10 minutes or so, as we would get intermittent ROSC literally for a minute or two, back to VSA. So again, during one of the intermittent ROSC, we got him to the table, went VSA, ran it again, intermittent ROSC, scanned his head, and then VSA again. So CT head showed a potential subarachnoid hemorrhage along the left Sylvan fissure. And then, so we were still doing CPR while we left the CT scanner. And so I went and spoke with his parents as well as his partner. I explained to them that this did not look good and is likely catastrophic. And I asked if they wanted to come into the room when we stopped things, and they were very amenable and did want to be part of that. So he initially went VSA in pod B10 at 10:08, and we called it at 11:08. And that's when we subsequently paged the coroner, who happened to be Dr. Reeder that day. And so after we talk a little bit more, he's going to tell us about the postmortem on this case. Okay, so I'm going to hand it back to Dylan.
Right. So obviously a very stark evidence of death in the emergency department. So keeping that in the back of your mind as we cruise through the next bit of the presentation, and then we'll revisit it later. So just quickly going over some objectives that we're going to talk about today. We want to just discuss the coroner system in Ontario and understand kind of a little bit of the logistics of how it works. Appreciate when to activate the coroner's service and when not to. Get comfortable with death certificates. And if we have time at the end, we'll talk about some more case examples. So death in the emergency department, not something uncommon that we face. Stat from the States says about 11% of all deaths occur in the emergency department. And if we kind of extrapolate that in Ontario, there's about 100,000 deaths per year. And of these 100,000 deaths, the coroners and MEs investigate approximately 15 to 20%. So we're talking about 20,000 deaths in Ontario get investigated by the coroner system. And then again, if we extrapolate 10% of those happening in the emergency department, certainly something that we have to know how to deal with. The first thing that you have to decide when a death occurs in the ED is whether or not this is going to be a coroner's case or not, because that's going to have big implications on kind of what algorithm you're going to take moving forward. One with the family to let them know what's going to happen next, and then also logistically, if you're going to start pulling tubes, pulling lines, making it more visibly okay for the family, or if you might not be able to do that if it is a coroner's case. So who is the coroner? Who is this strange person that you get over the phone and all of their wealth of knowledge? Is it this guy? Not quite. That's maybe one of the most famous or typically TV present people. This guy, who I didn't know who was, but Quincy, who I'll let Dr. Reeder refer to later for the relevance to the coroner system in Ontario. But again, maybe not quite exactly who the coroner is. And then most recently, the Canadian TV show with the name as its title maybe doesn't quite fit the exact role of the coroner either, at least from the preview that I watched on YouTube. So a coroner is either the presiding officer of a special court, a medical officer, or an officer of law responsible for investigating deaths, particularly those happening under unusual circumstances, with their kind of motto being speaking for the dead to protect the living. So let's get into it a little bit further. The coroner system varies province to province, and in Ontario, we have the largest system with approximately 330 coroners in total. Ontario has an all-physician system, which I believe is the same as Nova Scotia, but that varies from province to province. In Ontario, there's 9 regions. We're in London being the quote-unquote West region, and the coroners are composed of family physicians, pediatricians, and emerge docs mostly. But again, they're all going to be physicians in Ontario. To become a coroner, you have to complete the coroner's training course. You're operating under the jurisdiction defined by the Coroner's Act, which we'll go into, and you operate under the Office of Community Security and Correctional Services. The main role of the coroner, as per the Coroner's Act, is threefold. So one is to determine the cause of death and manner of death. And specifically, we'll talk about those two as separate entities further and ensure we kind of understand the difference there because it is important, and determine whether or not an inquest is necessary. So our job as kind of emergency physicians are more to determine when we should be involving the coroner. Coroner's job is to determine whether further investigation is needed. And then thirdly is to collect and analyze information about the death and circumstances surrounding it to try and prevent further similar events happening if possible. So I've just included the link to the Coroner's Act here in case anybody's up for a little light reading after the presentation. It's only about 1 or 2 pages, hey, Dr. Reader. It's quite long. So how to call the coroner in Ontario. So initially, we contact the coroner's dispatch and at the number listed on the screen. And you're connected with a representative who takes the kind of initial broad stroke definitions about the case. So a little bit about the person, their information, and why you believe you need to chat with a coroner. And then you get connected to a coroner on call and discuss any of the specific details about the case and decide whether or not it will be up for investigation. Really, anyone can call the coroner, anybody who has any concerns or questions about the case. Mostly from what I've seen is usually the MRP or the resident, but any member of the healthcare team, police, fire can call if they have any concerns. So now we'll get into the next part of the presentation on this manner of death, or how to die in Ontario at least. So the manner of death, differing from cause of death, like we referenced earlier, is classified based on the type of conditions under which the death and circumstances that occurred. So this is kind of the broad strokes of really what happened and not necessarily the specific cause of the death. And this is what has the implications for public safety and potential funding and preventative care moving forward. So there's 5 broad classes, manners of death in Ontario. So natural death, accidental, homicidal, suicidal, and then this kind of black box of undetermined. So we'll just briefly go through the 5 ways here. So natural, or by natural causes, is by far the most common manner of death. And this is where there's been no intervention. It doesn't need a coroner's call. And this is, the 1 out of the 5 scenarios where we're not going to have to involve the coroner. But again, natural, as easy as it sounds, is, what does that really mean? It sounds like can be very easily determined, but oftentimes there's a question about, was this natural? Was there something else at play? And in all fairness, this is directly pilfered from Dr. Reader, but to refer to the but-for principle, to kind of ask yourself the question is was this a natural death or not? So, if the injury didn't happen, would this person have died? So if it's no, then you're thinking that this must be like a non-natural death. So, if but for the large stab wound in their chest, would they have died? Probably not. And therefore, it's not natural. Kind of just rehearsing that mental exercise, if you're ever unsure, can be helpful in deciding whether or not this was a natural death. Accidental, a little bit maybe more straightforward. So any MVCs, any traumas, falls, sports injuries, and then any restraints while in police custody that results in death, all are obviously coroner's cases, as these are not typical or expected deaths in any case. And with all accidental or deaths, there's a specific section to complete on Form 16 on the death certificate. So just a little example here. I guess in regards to time and for Zoom sats, we won't delve in, but this is Reggie Lewis. So he's a Boston Celtics player who had a cardiac arrest during practice and ended up resulting in a coroner's investigation revealing he had hokum. So again, just something that got investigated, had a little bit more closure for the family, and got a better cause of death in the end. So this is the little section on the Form 16 that we're all aware of for accidental or violent death. And just know that if you're ever kind of proceeding to this section and saying, like, should I be filling this out? Maybe go back in your head and say, maybe this is something that we do need to call the coroner about. And moving on to suicide, the third out of fifth manner of death. Again, sounds very simple, and suicide attempts that results in death, but can be difficult to fully determine. So this is why we want to involve the coroners to help us decide whether or not this was the manner of death or not. So again, you're kind of balancing the probabilities. Is it more likely suicide? Was this, an intentional overdose? Was this accidental? Was this kind of like a quote unquote change of heart, or failed resuscitation, or failed rescue attempts? And we don't know often in the heat of the moment, in the 15 minutes of resuscitative efforts that we do in the ED, and that's why involving the bigger team is important here. Just of note, the manner and cause of death will be based on the initiating action. So if it was an initial suicide attempt, that's likely what will be on the death certificate. Homicide, a little bit more straightforward. Death by another person, any first, second degree murder, manslaughter, or infanticide. Also quite a bit less common. So in 2021, across Canada, there was only less than 800 homicides reported, accounting for only 0.2% of all police reported violent crimes. So not zero, but certainly less common, and not the predominant case that we're going to see. And then finally, kind of this undetermined, section of manners of death. So this is when we really don't have any idea of what's going on, which certainly does happen. If you think about, cases that you run into in the emergency department, you have a patient coming in VSA with a history of substance abuse. Maybe they have a history of CAD. They've been presented multiple times for a variety of things. Was this an overdose? Was this an intentional overdose? Was this, was it just a vasospasm? Did they just have a big MI? So we don't really know in the heat of the moment. And so from our point of view, it's undetermined, and then we can involve the coroner, or will involve the coroner, I should say. And this might change what the manner of death is going to be based on their inquisition. So just kind of overviewing again when you're going to call the coroner. So any accident, any homicide, any suicide, anything undetermined, and I believe any child under 5, Dr. Rudy, you can correct me there if that's inaccurate, and anytime you're unsure. So I've certainly called the coroner a couple of times when it ended up not being the case, but it's always been a good discussion, and I've never certainly gotten yelled at for calling. So it's always helpful. They're always there to just run things by them, and it's better to be safe than sorry in certain instances, for sure. This is just an excerpt from the Coroner's Act, and just kind of reviews what we talked about, but I'll just draw your attention to C and E there. As additional considerations to call is any pregnancy-related deaths, or any death resulting from something that the patient wasn't known to have. So anything they weren't being treated for that you're going to say is their cause of death is something that you want to involve the coroners for. So now we're going to move on to the cause of death. So the meat and potatoes of the Form 16, and certainly something that can cause some trepidation on what to write on the form. So specifically, the cause of death is the underlying medical diagnosis or diagnoses that ultimately led to the patient's death. And if you refer to the section of Form 16, the death certificate here, you can see that there's two sections involved in this part one, is the immediate cause of death and then the antecedent causes of death. So the immediate cause of death is the first line only, and that's the direct or the most current portion of the disease process that resulted in the patient's passing. And then following this, we can get into the antecedent causes, if there are any. And again, you don't really have to fill these out, but if you have the more information, the better, the more information, the better to include on these for vital statistics. But these are the things that are involved in the disease process, so have to be, again, related to this disease entity that can kind of preceded what the primary cause of death was. So we'll get into some examples here. So a little bit of terminology. Again, the cause of death differing from the manner of death is also differing from the mechanism of death. So I think we all know this, but you can't write cardiac arrest or respiratory arrest for a cause of death on a death certificate. You'll probably get a little bounce back. And again, it's not helpful for the vital statistics and in the moving forward for it's not going to be helpful for any data analysis. You also can't list any kind of non-specific conditions like heart failure, renal failure, hemorrhage, sepsis alone, as again, it's not really encompassing that primary disease process that's driving that, it was driving the death. So a little trivia here: the 5 most common causes of death in Canada, at least in 2020, were cancer, heart disease as number 1 and 2, and then COVID rounded out the list at number 3 with just over 16,000 deaths in 2020, followed by accidental or unintentional injuries, and then CVAs coming in at number 5. So some common causes of death I just have listed here as some other commonly listed on the Statistics Canada website. And then other significant conditions. So this is the next part of the Form 16, is kind of that part 2 underneath part 1, where you listed your immediate and then antecedent causes of death. Now you're getting into the other significant conditions that led to that led to their death, but not necessarily the conditions that would have been involved in the primary disease process. So, the patient who dies of an MI because of their coronary artery disease, because of their dyslipidemia, who was also a diabetic, smoked, and was obese, those things are obviously quite significantly contributory, but again, not in that primary disease process. So this is where you would put those other significant conditions. Still helpful to know for the vital statistics, but again, just a little bit separate section here. So often we run into some circumstances where we're certainly not sure exactly what happened, but we have a pretty good history of maybe a couple things that are going on. So the classic short of breath patient who passes away. So was it COPD, was it CHF? Taking into consideration their past is the best that we can do. So it's all based on, best guess or balancing probabilities and, clinical gestalt. No one's going to hold you to 100% to make sure that you're always right, which we certainly are not. So taking into account their pre-existing conditions. So if they've been to the ER 6 times in the last year for a COPD flare, treated with Ventolin and steroids, and went home, certainly walks like a duck, quacks like a duck. So certainly would be reasonable to put that as the cause of death. Another thing that is common, maybe less so in the ER, but certainly potential to have really no idea of what's going on. In our cases, maybe they come in VSA, it's an unknown, you have no idea what's going on. Likely in those cases, you're involving the coroner for sure, because it's probably in that undetermined category. But other instances, it is okay to list natural causes with exact cause unknown. Again, for our purposes in the ED, we're probably going to be involving the coroner in anything that we would be considering putting this in. But for those nursing home patients or things like that, it is a reasonable thing to put on the Form 16. And just going back, if we don't know, if you're thinking about multiple things, it all goes back to, this balance of probabilities and the standard of proof. So as long as you're on the right track and, you have relevant evidence to back you up, you have some, biochemical radiographic things to point you in the right direction, no one's going to fault you for using your best clinical judgment and deciding on, we have to pick something. So deciding on a cause of death is not our forte in the best of times. And then just the last little section here on the Form 16 is this dreaded box on the right-hand side, the approximate interval between onset and time of death. So this can be tricky, especially when we don't know the nuts and bolts of the patient's past medical history. So just a couple tidbits about this is that you want to list things in chronological order, obviously, with the most immediate at the start. So again, that's going to be your immediate cause of death and should be the most current or the soonest thing. So that's your MI that's been occurring for the last 5 hours. And then subsequently listing ascending chronological order. So coronary artery disease for the last 3 years, dyslipidemia for their whole adult life. A little key point here is that if there's no quote unquote acute cause, it's still reasonable to list their chronic condition as the most immediate cause of death. So, COPD, dementia, metastatic breast cancer. If we don't have a big recess that happened, this is still reasonable to put in place there. I have a little star beside MI and COPD just to make sure that I reference that abbreviations, medical short terms, are not acceptable on the death certificate. So putting MI specifically or COPD is not acceptable. You'd have to spell out the full term. So chronic obstructive pulmonary disease. And so with all of this, we all know all these things, but how do we do? So this is a study from Scotland, listed causes of death over the year, I believe, that presented to one emergency department. I couldn't find any statistics for North America or Canada. But in this case, they took 63 of the cases that presented that were subject to medical examination. And of the 63, they didn't do that great. They were about 60% wrong. Or 60% right, 40% of the cases, the ME changed the cause of death. So even with, best clinical gestalt, trying, our best to collaborate with the history, with the physical exam, with all our extra investigations, we're still not by any means perfect. So that goes back to this kind of balance of probabilities and just trying our best with the clinical gestalt. So, after all of this, we've either decided we're calling the coroner or we filled out our death certificate and, we've briefed the family. So what happens? What's next? So once we've called the coroner, I'll say the body and the deceased is the responsibility of the coroner. Again, this goes back to not altering things, not changing things, not pulling tubes, not taking out IVs, not, as much as we want to make things more palatable for the family. In these cases that we're discussing with the coroner, unfortunately, we just cannot. And specifically, this is difficult. This can be difficult in, the pediatric population. Thankfully, we don't deal with this quite as much as maybe our PDM colleagues do, but again, discussing with the coroner in these cases and, not being able to have the parents, move their child who's recently passed away can be certainly difficult. So briefing the coroner or chatting with them about this to see if this is a possibility would be helpful. And maybe they can say it's okay for them to hold their child, but maybe it's not. But it's just important to know before going in and letting them know. So after the coroner's investigation, deciding on whether a postmortem is necessary is one decision that the coroner has to make. So interestingly, London here at LHSC is the tertiary referral center for all of Southwestern Ontario. This is where all of the postmortem investigations for Southwestern Ontario take place. And they do over 600 exams annually. And also the forensics department works with police and the coroner's office to investigate these forensic cases. I believe they do over about 400 cases a year as well. So after the postmortem is done, the investigation is done, who gets the report after all of this labor-intensive investigating happens? It's the family and police. Unfortunately, we don't get the report. The hospital doesn't get the report unless there's question on whether we can use it in quality improvement measures. So only the autopsy will be presented to the hospital if for some reason we think that we could improve our level of care, potentially getting to patients sooner with shortness of breath, or identifying COPD before one point in our triage system. And at that point, we can ask the coroner for the report and the autopsy results, which certainly happens quite frequently. The reports do take quite some time to develop. As you can imagine, there's a lot that goes into these reports and can take 2 or 3 months longer if there's determination that genetic testing needs to occur. And so this is why it takes so long. Post-mortem by the pathology, the medical examiner team, and then reviewing those results with the coroner. And in that time, the coroner's going house visiting, involving police and chatting with the police, getting the records from the emergency department, talking to the family physician, getting records from there, gathering more information about the patient's past medical history, reviewing the talks, reviewing the labs from Emerge, potentially discussing it at a case conference if there's questioning. So as you can imagine, this all takes time and is not a 5-minute job that we can certainly do in the emergency department. So, after all of this, we've decided on involving the coroner, getting this intensive report completed. What's the point? Why do we do all of this? So filling out the death certificate, like I've alluded to in the past, is important for vital statistics, and that subsequently translates into funding for preventative medicine moving forward. Again, it's based on the best available evidence, so it's important that we try our best at least to accurately fill out these death certificates, and that's why the antecedent causes and the other contributing causes are helpful to put onto these forms. And then all of the forms get centrally collected in Thunder Bay, and then somehow through the magic of administration get collaborated into stats and then analyzed. So this is just a little quote from the United Nations back from 1955, just showing how important death is for preventative medicine. So just in last-ditch effort here, I am just cognizant of the time, going over a few things not to do, or maybe that you shouldn't do or don't have to do. So first things first is not impeding the coroner's investigation in any way, as potential directly from the Coroner's Act here for $1,000 fine and or 6 months in jail. So not ideal. So just cooperate. The other thing is telling the family that there won't be an autopsy if you're involving the coroner, because this is not our decision to make, unfortunately. And if it's deemed appropriate that there needs to be an autopsy, one will be completed. And you don't want to be telling the family that there won't be an autopsy, and then the coroner comes in and says that there is going to be. It can be obviously quite distressing for the family. And then we talked about not using medical abbreviations. Another common myth is that you have to report all deaths within 24 hours after hospitalization, which again is not necessarily true. Something that maybe you may have to for other reasons. And if you're unsure, always again, reasonable to call. We talked about this, attributing the cause of death to like an organ failure or, a mechanism of death. So again, not an acceptable thing to do, or attributing cause of death to quote unquote old age or, senility, failure to thrive. In these cases, maybe using that, natural causes of unknown exact origin or calling a coroner. You also don't have to complete the death certificate if you are calling the coroner. Oftentimes, this is something that they will do, or at least, chat with them to make sure that closing the loop is that they're going to complete this. As again, we don't know exactly what's going on, and we may just be, filling it out inappropriately. Don't leave the time interval on the cause of death blank. It's better to put unknown rather than leaving it blank, even if you don't know how long they've had coronary artery disease, putting unknown rather than leaving it blank. And then more of a logistical point is making sure to place the identification tag on the deceased before transfer to the morgue, as you can see how that would be a bit confusing. So now I guess I'll turn it over to Dr. Reeder maybe to just kind of go back to that case from the beginning to chat about the postmortem and cause of death on his end.
Sure. Great. Thanks very much. So I don't actually have any slides, so I'm just going to talk because I think Dylan's nicely presented everything so much today. Before I go into this though, just there are a couple of questions that came up. I'm going to address. So Justin asked, is it acceptable to write as a cause of death suspected X, suspected Y? It's acceptable, but really, you can do it. But really, a death certificate is usually best likely diagnosis based on incomplete information. So you could do it, but you don't necessarily have to. But it's to ask Justin's questions is okay. So Michael asked, is there a charge payment for the autopsy? So if the coroner says, I don't need an autopsy, the family says, no, I really want to know why Uncle Gert died. Are they charged for it? The answer is for hospital autopsies. No, they're not. If it's a hospital autopsy. Now, there are places, that's a good question because there are places where they do private autopsies. The US has a lot of services that do private autopsies. That doesn't exist in Ontario. If anyone's curious how much an autopsy costs, it starts about $2,000 and goes up from there. But a hospital autopsy, the family is not charged. So if someone dies in the emergency department, the family requests an autopsy, it's a hospital autopsy, is no charge to the family. The question was, just a couple of questions. Death under 5, should you call the coroner? I think it's prudent to. If you look at, there are kids who die under 5 who have unexpected death. So say you've got spinal muscular atrophy, which is a horrible disease, and you develop respiratory failure and die. And you're 2.5 years old. This isn't necessarily a coroner's case, but it's something that I think would be prudent for the emergency physician to call the coroner to discuss. Certainly our colleagues in the pediatric critical care unit usually call about those cases, if nothing else, just to ensure that the T's are crossed and the I's are dotted. And they may not be coroner's cases, but it's one that's worth discussing, because if you discuss a case with the coroner and the coroner says it's not a coroner's case, that's still documented. So it's in the system. So if someone comes back, 3 years from now and says, well, listen, this Dylan guy didn't dismiss the case, should have been a coroner's case, why didn't you talk with the coroner? We can go back and say, oh, but he did, and here's the conversation, and here's why we didn't accept the case. So I think it's prudent to do that in cases like that. As mentioned, in coroner's cases, the coroner always does the MCOD, so the medical cause of death to Form 16. So that you don't have to worry about that because the coroner, and it's frequently filled in some days afterwards because as noted, the investigations do take some time. So let's return to this case. So postmortem examination. So the postmortem was done up at University Hospital. So in London, the morgue at University Hospital does all the postmortems. Oh, as well, sometimes family asks if they can see the deceased in the morgue. Despite what they show on TV, the morgue at University Hospital, like most forensic morgues in Ontario, does not have a viewing room. It's a functional morgue with 3 autopsy rooms, case room, storage facilities, etc., it does not have a room to view bodies in. So the answer to that is pretty much always no. So what we'll do is arrange for a timely autopsy as quick as possible to get the deceased to the funeral home, who have the facilities to allow for respectful viewing of the deceased. So that's something as well to be aware of. Further to Dylan's point as well, if the family wants to view the deceased before the coroner arrives, usually it's okay to view as long as they don't touch. And again, with pediatric cases, there may be a bit of sensitivity around that, and we're aware of that. And we can sometimes will advance, say yes, no, the family mom can hold the baby while we're waiting for us to show up. Unless there's a suspicion of criminality. So if there's criminality in those cases, probably not. That does, as noted, doesn't happen all that often. As well, by the way, in terms of homicide, it's important to understand when the coroner makes a judgment of homicide, all that means is one person killed another person. And our colleagues in the police services sometimes get upset. Not that it happens all that often, but if a policeman police constable shoots someone in the pursuit of their duties because of mortal dread of their life, that's a homicide. It's not a murder though, because murder is a legal term. Homicide is a manner of death, which is something, an important distinction that not a lot, some people just don't grasp. So let's return to this case. So we have this guy, this gentleman who has this past history of having had ITP earlier, antiphospholipid syndrome, and presented being unwell. So postmortem examination showed evidence of widespread multi-organ dysfunction. There was a subarachnoid hemorrhage. There was a very low platelet count, but the key finding on postmortem was actually a robust growth of Streptococcus G in the blood. So cause of death in this case was actually strep G sepsis. So the comment that was originally made, this is septic shock, is exactly right, because this patient shows up in agonal septic shock due to Streptococcus G, which is a very interesting organism. So Streptococcus G, for those who've never heard of it, which is probably most people, is primarily a large animal pathogen. So it's actually primarily seen in horses, cattle, things like that. Sometimes causes disease in people, usually mild. However, cases of invasive disease and death have been described in the literature. Interesting enough, it's not reportable because the reportable diseases, the reportable Streptococcus in Ontario to public health are Strep B in a neonate and invasive Strep A are both reportable to public health. In the case of Strep A, ASAP by telephone. Now, I did report this one to Strep G to the Office of Public Health because it's uncommon. And if you go back and look at the history, so this guy was living with his family house in London, and there were a bunch of people that had been sick for a few days beforehand. So we did report it because we wanted them to follow up in case anybody else was ill. Turns out nobody else was, well, people were ill, but nobody else had Strep G, which is fortunate. So the cause of death in this case was septic shock due to Streptococcus G sepsis, and a contributing factor was the antiphospholipid syndrome, because it likely contributed, at least in some respect, to his thrombocytopenia. As noted on postmortem examination, there was a subarachnoid hemorrhage, and we think is probably related to the thrombocytopenia in the presence of overwhelming sepsis. So going back to the QI point, so, as emergency physicians, what could have been done differently? I have to say, I don't think anything. If you go back, and I think the treatment team, did a full court press on this. And unfortunately, when you show up in agonal septic shock, there's not much you can do to reverse that. As we all know, septic shock is one of those things that you want to get onto promptly before they show up with metabolic acidosis and hypotension, because once they get into that fatal cycle, the non-virtuous cycle, that at that point, really as Caesar said when you cross the Rubicon, the die is cast. So that's kind of this case here. It's a very unfortunate case, quite tragic. Young guy working in the financial sector. Had family who loved him and partner who loved him. So there was a tragic case who, despite presenting to tertiary care hospital emergency department staffed by well-trained physicians and with superb nursing staff, was unable to be saved. So the learning point from this really is I guess it reinforces our importance of septic shock protocols and early treatment of septic shock in case of suspicion. Now, there's a question, Dealey asked a question. Age may be different in court involving cases of NDD. and nuances in TGL and in okay. All right. This is why I hate acronyms. NDD stands for, Dylan?
I think neurological determination of death.
Ah, yes, there is actually. So these are typical cases not in the emerge, but in the critical care unit, we'll often get neurological determination of death and move forward for organ donation. Depending on the cause of the neurological death, the coroner's office may or may not be involved. We usually are because they're often traumatic. So it's often trauma. So we will be involved because it's in that case it's a coroner's case because of involvement in TGL, Trillium Gift of Life Network. So the Trillium Gift of Life Network actually works pretty closely with the coroner's office because most of the cases they get involved with are involved in traumatic death. So yes, so when that happens, when the determination of death is made, the coroner's office needs to get called. Coroner will call the care team as well as Trillium Gift of Life, and at that point have to work out a bunch of things. One of the things I have to work out is what's acceptable for donation. So is this going to need a full autopsy, in which case there's not much acceptable, or can we be selective? Now, fortunately, because of advanced medical imaging, we actually, and because of excellent healthcare, good keeping of healthcare records, we often can, in cases of traumatic death, actually have a fair amount of organs go to the Trillium Gift of Life, because we can say, for instance, okay, this person was involved in a car accident a week ago, suffered a major head injury, is in the ICU, determination of death. So do we need to do a full autopsy? Well, they've been imaged. We know exactly the injuries. They've been seen by Gen Surg and the trauma team and the critical care units and the emergency department. So we know exactly what went on. So to answer the 5 questions, which is the 5 questions every coroner asks are: who died, where they died, when they died, and what the cause and manner of death. So to answer those 5 questions, I've got those answers. So I don't need a full autopsy. Now, some cases require at least a partial autopsy. If you're the driver, the Coroner's Act quite clearly says you have to have at least some degree of autopsy. If you're the passenger, not necessarily so. So I've been involved in it. Unfortunately, I don't know why, but since January, there have been a whole bunch of auto crashes out in the county with fatal outcomes. So in those cases, we sort of sort through what goes on in terms of who gets the autopsy, who doesn't, and donation, et cetera. So we've been able to actually work with the Trillium Gift of Life and families about donation. For families, being able to, in this circumstance, are always tragic because they're usually youngish people who get involved in these. Being able to have their loved one contribute organ to Trillium Gift of Life is often good for help to bring closure to the families and a degree of solace. So we definitely try to do that. So those are good questions. So in this case, as we talked about, manner of death is natural, because infection, sepsis is a natural disease. Cause of death, I was going to put down group G sepsis, with contributing factors being antiphospholipid antibody syndrome. So that's what I wrote up for this one. And again, as you talked for filling out certificates, cause and manner of death, there's long prison splitters. So you can say the person developed dehydration or developed renal failure because of dehydration because of advanced Alzheimer's disease, which is totally acceptable in the context of 2 days, 1 week, many years. Or you can just say Alzheimer's disease, because bottom line is, what the coders care about and what the serum is public policy is exactly that. And further to Dylan's point about why it's important, Dylan mentioned an interesting statistic way on, which is the number 1 cause of death in Canada is is cancer. If you would have looked at that 10 years ago, you would have said heart disease. And that's true for most developed countries. So for instance, in the US, the common cause of death is still heart disease, as it is in the UK, as it is in Germany, as it is in Finland. But Canada is a bit different. Canada, France, and the Netherlands, the most common cause of death is actually cancer. And why is that? Is it because we're cancer-ridden paradises? No, it's because we decreased heart disease deaths, because public policy recognized the issue. So things like aggressive treatment of hypertension by family physicians, treatment of dyslipidemia, managing lifestyle, encouraging exercise, treating diabetes appropriately, has reduced the burden of death of heart disease. So the cancer stayed about the same and heart disease dropped. So it actually matters. So this stuff actually matters. And this is a good example of how it makes a difference. Oh, yes. And Allison said that Prince Philip's cause of death is sealed. Yeah. Yeah. The Queen died of old age. Well, if you're the reigning monarch, our reigning monarch, you get a certain degree of discretion as to your cause and manner of death. And the House of Windsor certainly has longevity on its side. So perhaps they're the one exception in dying of old age. Okay. So
Awesome.
with that, I think our time is up, but anybody has any questions or anything, please don't hesitate to give me a call, drop me an email. Love to chat. And there we go.
Yeah, thank you so much, Dr. Reeder, for coming and all of your help with this whole presentation. Yeah, I think we are kind of wrapped up for time wise, but I just wanted to throw a couple references up on the slide there. Like you said, it is a traumatic thing, can affect us all differently. So there's a lot of resources out there. Don't hesitate to reach out. And thank you everyone for attending. And again,
I'll just reiterate a thanks to Dr. Reeder. This case was quite bothersome to me, obviously, wondering whether or not we'd done everything we could. So I actually had left a note for Dr. Reeder with my LHSC email asking him to please kind of keep me up to date on any findings. And he was very gracious and emailed me back the next day. So that's kind of where this all started. So again, thanks, Dr. Reeder. Thanks everyone for attending. And we hope you have a great day. Bye, everyone.